Yes, I have downloaded the folder.
Okay. So we'll be sharing also the some of the files in the chat box as well if we can.
Okay.
Okay, we can actually share files through the messages in here. So you have guys to go into the
I'm
e-learning and
uploading them on
download.
the drive. Just I'm sharing a link. Just give me a
Oh,
second.
okay. Okay.
Oh, thank you very much. I just want to catch attention of the female students here. Please inform the female students to come to this link. If you, I think you have already done so. So before I start the class, I would like to request you to send the messages in your WhatsApp group or whatever social group that you have, and so that everybody join. So it's 9:05. Without wasting any more time, we should start today's class. Do you see the slide?
Yes, doctor.
Okay. So today we will talk about the randomized control trial. Do you remember in the first lecture what we talked about? Anybody? This is our second lecture.
Yes, we talked about the study designs starting
Study
from the
designs, yes.
this one.
We talked about the study designs and other things, and we briefly touched. And today we will talk in details about one of the design, actually the best design of all designs, randomized control trial. Why should we talk about this design in this block? Because you have a practical related to the randomized control trial. Okay. So if you remember from the last class, we talked about that studies are two types. One is observational, where the observational study means the investigator only observes but does not interfere. And in this type of study, you have cross-sectional, case control, and cohort. But the other type of design is the experimental design. Experimental design means where the investigator interferes into the study. How does he interfere? By giving them the treatment or giving them the intervention. So he actively interfere in the participants' life. But in the observational study, we do not interfere in the people's participants' life. We just follow them, observe them, record their information. Now, between the observational design and the experimental design is superior. And why it is superior, we will know it in a second, although we talked about in the first class as well. So before we go into that, we need to know what are the experimental studies. There are main two types. One is the true experiments and the other one is the quasi experiment. Quasi means like kind of like halfway, not really, not true. That's what quasi means. So true experiments is the randomized trial, which we will talk today. But the quasi experiment would be, say, if you take a community, like say Bukeria, and you want to you want to like you want to like see what is the effect of giving the folic acid to the pregnant woman. So e- everybody that gets pregnant in Bukeria, you give them the folic acid, and at the end of their pregnancy term, you look at the child's condition, like is it the normal weight or the like less than normal weight, or what is the percentage of the stillbirth? These are the things you hope that giving the iron and the folic acid will reduce all of these things. So you assess them in the beginning or in the and another time at the end to see the difference. So that will be a temporal comparison. Another type of quasi experiments you can do is that you take two communities, okay, Bukeria and Unaiza. In Bukeria, you gave the intervention, whatever intervention, say in this case, iron and the folic acid to all pregnant women, and in Unaiza, you withheld that, and then you see what is the effect. But then the question is, why it is called quasi experiment? Why it is not a true experiment? In the first example, where you did a pre and post, you didn't have any control group. No control, no, it's not a true study. Like whether it is an observational study or either an experimental study, you need to have a control group. A control group is like a mirror. If you want to look at yourself, you need to stand in front of the mirror. If you don't have a mirror, you don't know how you look like. The same is that without a control group, you really cannot tell or prove the efficacy of the drug or the intervention, whatever you are giving. So that's the pre and post. That's why it is not a true experiment if there is no control group. In the second example, you have a control group between Bukeria and Unaiza. Bukeria received the intervention and Buraida did not receive the intervention. So why we are saying it is a quasi experiment? The quasi experiment we are saying is because here we did not do any randomization. We just took two community, gave intervention to one community and withheld it from the another community. Without randomization, there is no true experiment. So one time there was no control group and the other time there was no randomization. So that's why these are quasi experiment. So now you know the true, if you want to have a true experiment, the randomized trial, I don't have to explain it to you what should be the characteristics of the randomized trial. You can deduce it from the characteristics of the quasi experiment. So randomized trial, it must have a control group and there must be randomization. If these two conditions are fulfilled, you can call it a true experiment, a randomized trial. Now, randomized control trial, I told you, is the best design available. And it is also called the gold standard. And why it is called the gold standard? Because of two things. One is the randomization. Okay, randomization. As you know that in the last class we talked about, in biomedical science or any research question can be broken down into two pieces: exposure and the outcome. And we find that our goal is to establish the true relationship between the exposure and the outcome. Are they related or are they not related? But like real life, this kind of association is also complex, because nothing is life is so simple that there are two factors. There are many other factors affect that relationship, and you need to control those factors in your analysis or in your design. So these are we call confounders of that relationship. Most other design can control the confounding, but in a very imprecise manner, a very kind of a uh, imperfect manner. But in RCT, we control for confounding through randomization. So because randomization, if it is done properly, makes the intervention and control group similar in every respect. The only difference between the two is one group get the intervention, the other does not. And so if at the end of the experiment there is an effect, that must be due to the intervention. No other factor can be attributed to the difference in the outcome. Why? Because all other factors were similar between the groups. So if there is a difference, it must be the intervention. So randomization controls the confounding. And there are other characteristics of the RCTs. Okay. In addition to randomization, like blinding, allocation, concealment, we will explain. These prevents biases, because any study is subject to biases from many front. So RCT is the gold standard for two reasons. It controls for confounding, and RCT is the design where minimization of biases is possible. Like you can, if you are very careful, you can prevent biases, particularly the selection bias. That's why it's a gold standard. Now, when we think about the randomized controlled trial, there are two types: therapeutic and preventive. As the name implies, therapeutic trials deals with the patients and preventive trials deals with the healthy people. I shouldn't say healthy people, not diseased people. So patient, therapeutic, and healthy or non-diseased people who are at risk of developing the disease, they go to the preventive trial type of trial. What is the objective of the therapeutic trial? As you understand, the patient comes because they need to have a cure for the disease, okay, or diminish the symptoms. Okay. What is the objective of the preventive trial? So that they don't develop the disease. Okay. Patient already developed the disease. So what outcome they are interested in? Either cure, or if there is no cure, how to reduce the symptoms. And for some diseases like cancer, they don't want the cancer to come back. So prevent recurrence or death. That's what, once you have the disease. But if you don't have the disease, your number one goal is to how to avoid the disease, how to prevent the disease. So that is the theme of the preventive trial. Let's look at some of the example, then it will be clear. A therapeutic RCT. Say you are working in an intensive care unit and you are using a particular type of antibiotic, okay, for infection. But now in the market there is a new type of antibiotic came that was publicizing that it is better than the new one. So what you do, if you are an ICU physician, you randomize your patient into two groups. One group you give them the old antibiotics, and the other group you give them the new antibiotics. And then you follow them, see what is the cure rate. You look at the cure rate of the new antibiotic compared to the cure rate of the old antibiotics. And if the cure rate are the same, then you conclude that the new antibiotic is as effective as the old antibiotic. If the cure rate is the new antibiotic is higher, statistically, you go for the new antibiotic. But it often the case, maybe the old antibiotic will be better than the new antibiotic. So it allows you to make a decision. Say you find that both antibiotics are equally effective in curing, then you think about which one is cheaper, which one is easier to administer. That will help you to make the decision which antibiotic will you use. But in order to make that decision, you ran an experiment, and this experiment is therapeutic because you dealt with patients, intensive care unit patients. So this is an example of the therapeutic RCT. Now I will give you the example of two preventive RCT. Okay. And this one is the primary prevention. What primary prevention? You know that older people, I'm talking not coronavirus, but influenza, flu. When the flu season comes, we all ask the old people to take the flu shot, because if they don't and if they get influenza, the chance of pneumonia is very high. But as you know that telling people one thing and doing another thing is a completely another matter. So you are the doctor in the Al Qasim region in the Bukharia. So you want to do an experiment. All of your older patient that comes, they you randomly assign them into two group. In one group, you when they come, you just tell them during the visit, hey, this the flu season is arriving, please get the vaccine. That's about it. And then you don't tell them anything because you have done your part. On the other group, the intervention group, you started sending them text messages, say every week, if you haven't taken your vaccine yet, please do so. You can find the vaccine over there, either at the doctor's clinic or at the primary health care center. You are sending them reminder. And then at the end of the flu season, you compared what is the vaccinated rate between the two groups. And you found that the vaccinated rate in the reminder group is higher. So then you concluded that reminder works. And that's why many public health program in campaign, reminder is a strong component of the intervention. If you remind people, they will more likely to do it. Okay. So this is an example of the preventive RCT, primary prevention. I should not tell you like what is primary prevention or secondary prevention. You should know it. Primary prevention is to prevent someone from getting the disease. And the secondary prevention is you test them so that you can catch the disease early. That's the idea of the secondary prevention. The objective of the secondary prevention is to catch the disease early, so that you can treat them and they get better. Because if you diagnose the disease late in the stage, maybe death will be more likely, maybe cure will be less likely. So you want to catch the disease early. Now, again, you are in a doctor's chamber. You are a physician, so and you're seeing that there is a lot of colorectal cases these days. And so, who gets the colorectal? Usually, people who are 50 years and older, and people who eats a lots of red meat, they're at higher risk of developing colorectal cancer. So what you do in your clinical practice, or if you are a say Al Qasim public health official, you randomly group them, these 50 years old, into two groups. One group will go like one group will receive the usual care. What is the usual care? They will go to the doctor's visit, and the doctors will usually, if he's 50 years and older, they will tell you that, hey, you need to do a colorectal screening. Okay, colorectal screening. How do you do the colorectal screening? There are many way of you can do the screening. One of the screening tool is called FOBT, fecal occult blood test. Whether it meaning that they examine your stool and they looked for the dead blood. So dead blood indicate that there is a bleeding somewhere in the intestine, and when bleeding happens, many reasons can give rise to bleeding, including tuberculosis. But one of the reason of the bleeding is the cancer. In the colorectal cancer, there is an internal bleeding. First in the little, so the stool comes black. And in the beginning, it's not, there will be only little bit of the bleeding. So you know that from the FOBT test early. So one group go to the doctors and doctor says that you need to screen. Okay, that's about it. It's your responsibility to do the screening or not. Other group, you tell them that you have to screen for FOBT every year. Every year when you come, you will do the screening. So, and you follow them for these two groups for 10 years, and then look for colorectal cancer. What is the colorectal cancer rate in the group that received annual test versus what is the colorectal cancer rate in the group that only received the doctor's advice? What do you think? Anybody? Which group you will see more colorectal cancer?
Maybe on the usual care.
Maybe on the usual care. Okay. Anybody else? Support. What is your name? Usual care. Who said that? What's your name?
Yes, me.
Very
Aisha
good,
Mithil.
Aisha. Who supports Aisha? Okay. Rakan
Doctor,
Salha.
Yeah, I think that more colorectal cancer will be the people who didn't get screening every year.
Yes. Yes. That's what you would think. But in reality, you will find that the colorectal cancer rate is higher in the annual FOBT. It's the paradox, and I will explain what is why this is the paradox. You
Okay.
will see higher rate of colorectal cancer in the screening group. The reason is a simple thing in life. The more you look, the more you will find. Okay. So if you screen them annually, in terms of rate, the colorectal cancer rate will be higher in the screening than the usual care group. But that's not the whole story. The second part of the story is likely, if this screening is successful, that although more people of the colorectal cancer were detected with the annual FOBT group, most of them are very early stage colorectal cancer. And in the usual care group, majority will be on the late stage cancer. Although the rate is less, but the severity is high. So at the end of the day, if you think about which group has a better survival chance, it will be the annual FOBT. Although they have higher colorectal cancer, most of them will be the early stage, very early stage, and therefore you can do the intervention. You can resect that part of the colon or rectum, and you can give them chemotherapy, radiotherapy, and you can expect that they will get better. But if in the usual group, although they have less colorectal cancer, but many of them will be end stage colorectal cancer. So it will be difficult to keep them alive with the treatment modality that we have. Does that make any sense?
Yes.
Yes.
Oh, okay. Screening, whenever you do a screening, expect more cases, but expect early mild cases. Okay. All right. Now, you want to do a randomized control trial. Remember, randomized control trial, it's in terms of theory, in terms of how it is conducted, it's very simple. Simple yet very powerful. But in reality, when you want to do an RCT, you will find that this is the most rigorous of the design and most difficult study to do. One of the reason is humans are different. We are freedom loving people. We are not animal. We are not guinea pig. So you cannot, when you're the subject of your experiment is a human being, you can intervene, but they have the mind of their own. They may take the medicine, they may not take the medicine. They may come for follow-up, they may not come for follow-up. They may want to stay in your study, they may drop from your study, because we cannot force them to do this. Okay. And because of that, RCT in human is very difficult. But if you want to do in the RCT in the with the animal, with your guinea pig or the mice or the any other animal, it's easy, because animal don't have that freedom. So that's why RCT, doing an RCT with the human is a very, very daunting task. But anyway, what are the phases of the randomized control trial? One is the first, you have to enroll your participants. Then you have to randomize, and once you randomize, then you have to allocate whatever intervention it is. Maybe it's a drug, maybe it's a lifestyle modification, maybe some even a reminder, flu shot reminder can be an intervention. Whatever the intervention it is, whether it is a drug or a reminder, whatever it is, you need to allocate that to the intervention group, and then you need to follow them up for the study duration. Study duration, depending on the outcome, can be weeks or can be years. Whatever time it is, you need to follow both group. And during this follow-up time, you have to assess whether intervention group is really doing the intervention and the control group is not doing the intervention. It's like you have to check both groups. If the intervention group receives a drug, you have to make sure that they are taking the drug. At the same time, in the control group, you have to make sure that they are also not taking that drug. So control group should not take the intervention, and the intervention group should take the intervention. So you have to assess adherence in both groups. And then once the follow-up is done, then you have to analyze the data and interpret the result. So these are the like broader phases of the randomized control trial. We want to hear about RCT methodology. We will learn about the terminology, randomization process, stratification, blinding. We'll talk about the pragmatic trial, but the first four, very, 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 very important. Okay. Terminology. Whenever you read a randomized control trial, you always hear about the study population. Study population is really not a population. It is actually the sample, but it's a misnomer. We call it study population. So study sample, when you randomize them, you can randomize them into two groups, intervention and the control group. So if the study population is the sample, then what is the reference population? Reference population is, you, as I said, we always study the sample, but we want to generalize our result to a bigger population. And so whatever your study sample, the result that you have found, the population that this results belongs to or the is applicable to is called the reference population. So if your sample is the Bukaria woman, pregnant woman, about the folic acid and the iron, and you find that they are protective against the stillbirth, protective against the premature baby, then your reference population should be all Saudi women who are bearing children. So that will be your reference population. Assignment. Assignment is that when we say assignment, we usually say that assignment of the group, which group you are assigned to. Okay. Outcome is what is our, we are interested when we do a randomized control trial, we are interested in a outcome. Outcome could be death, outcome could be recurrence, prevention of recurrence, outcome could be prevention of the disease depending on the type of the RCT, or it could be reduction of symptoms, or outcome could be cure from the disease. That's the outcome. The another word that you will come across is called intention to treat whenever you read an RCT paper. Intention to treat means it's a powerful term. Intention to treat is that, you know, randomized control trial is by definition is a longitudinal study. And what do I mean by longitudinal study? There must be a follow-up. So at the beginning, you randomize them into two groups, intervention and the control group. And at the end of the follow-up, you assess the outcome. But what happened is invariably, as you are dealing with human, you will lose people during the follow-up time. Now, when you do the analysis, you have two options. Those who are lost to follow-up, you can exclude them from your analysis, or you can include them into your analysis. Intention to treat is when you do not exclude them from your analysis. Doesn't matter whether they took the medicine or not. Doesn't matter whether they disappeared from the study or not. They should be into the analytical sample. And if that is the approach you take, it's called intention to treat approach, and it is a better approach than the excluding them. Why? Because that's what you expect in the real life. In the real life, when you give a medicine, some people will be very disciplined and very serious. They will take the medicine. Others will not take the medicine regularly. If they feel better, they will stop. There are people who will not take the medicine at all. So in the real life, you will find a medley, all type of people. So you need to keep that into mind. So when you are doing the experiment, If you take the intention to treat approach, you are actually saying that doesn't matter whether they take the drugs or not, whether doesn't matter whether disappear from the study or not. Once they are randomized, I am going to always include them into my analysis, and that is the best approach. Bias free approach is intention to treat analysis. So if there is an intention to treat analysis, there is a counter terminology. If you don't do an intention to treat analysis, what is it? What it is called? It is called the completer analysis. Those who completed the study, you only uh, analyze them, but usually often give you the biased result. Yeah, like in the class, it's like analogy. In a class, there are a lot of good students, but there are also a lot of not so good student. So if you only focus on the good student, you will not get the real picture. You need to consider all of the people. Is clear?
Yes,
Yes,
doctor.
Mhm.
clear.
Clear. We need to. So randomization, I already explained it, but one more time. Randomization is a simple process. Think of it as a coin toss. So a person wants to enroll into your study, you said we're very glad, and then you said that let's see which group you will go. You toss the coin. If the head, they will go to the intervention group, and the tail, if they will go to the control group. You did the coin toss. So every time a person comes, wants to do the study, you do a coin toss. Now, in real life, we do not do the coin toss. We do a little bit of that. We use the random table, or that we ask the computer to generate randomly, like do a coin toss for us. Similar. Concept is similar. This is a very simple thing, but at the same time, it is a very, very powerful thing. If you do this thing to enough of a time, like if your study has 500 people or 1,000 people, what you will find that the people will be divided into these two groups, more or less equal number, because of the chance. But more importantly, these two groups will be similar in all respect. As I said, they will be similar in respect of their age, sex, BMI, race. You say it, measured or unmeasured, in all type of characteristics. They will be in balance, in harmony, in these two groups. Theoretically, I'm talking about theoretically. And then one group will get the treatment, and other group will get the will not get the treatment. So this is the randomization. But this randomization process should not be known to the not known should not depend on the patient. Patient comes and says that I want to be in the intervention group, or it should not depend on the investigator. Investigator knows this patient, it's his relatives. He said, okay, I'll put you into the intervention group. No. This lottery has to be influence free from both the patient, from both the and the investigators. It will be a true lottery. So it should not be knowable that which group. If you say that Monday is the day for the intervention, so the patients knows it, they will come on Monday, and nobody will come on Tuesday, which is the control day. So the assignment cannot be known in advance. Randomization usually applies to individual. We do the randomization to individual and not the group. We don't randomize group of people, but that's not totally true. That's why I put the word usually. Sometimes we also randomize group, but that's in a minority of the cases. Okay, analysis should be intention to treat, no exclusion after randomization, which also we do. So these are better approach, but not always followed. But the upper, that they should not be known, is strictly followed. Okay. Now, stratification. This is, do not equate. Stratification is not randomization. Okay. When the stratification comes, say, as I told you, like if you have a large enough sample, 500 people, 1000 people, okay, and you want to randomize them, you will expect that the groups will be equal in size and equal in distribution in character. But if your sample size is small, like say 20 people or 30 people, then this coin toss, just by chance, the group can be unequally distributed. And if the group is unequally distributed, you are in trouble, because then if the intervention, if you find an effect, you do not know, is it because of the intervention or because of the any inequality between the group. So maybe the groups will be unequal, not only in size, but also in terms of important confounder. Maybe one group will be older, other group will be younger, or one group will have more male, another group will have more female. But these are important confounder. So in that case, you can do stratified randomization. You can say, hey, I will stratify my sample into older and the younger. Okay, so I will take 15 older and 15 younger, and then within the older 15, I will randomize them into two groups, and the younger 15, I will randomize them into two groups. So at the end, I will have a representation of both young and old in the intervention and the control group. So if you employ that methods, it's called stratification. Stratification, often the common stratification variable are age, gender, race, or the multi-center RCT. It's usually the center. Like in the, if you do a case control, a randomized control study, and you enroll your patient from all over Saudi Arabia, from the different hospital, you can stratify your randomization by hospital. Every hospital will have a intervention and the control. If you don't do that, maybe one hospital will only get the intervention patients and not the control one. So that's the stratification. Blinding, very, very important. Okay, blinding is whatever intervention you are assigning, they should not, the participant should not know. It should not know. The investigator should not know. And I will explain why they should not know. Whatever the outcome you are assessing, the outcome assessor should not know who is this person from the intervention group or the control group. They must not know. And this not knowing the group status, whether this person is the intervention group or the control group, is called the blinding. Why? Because if we don't maintain the blinding, we introduce bias. You are the outcome assessor. Let me give you an example. You are the outcome assessor, and this study is about the effect of the smoking or effect of something, like effect of a factory worker. You know that smoking causes the lung cancer, or the certain type of factory, if it is a silica based factory or the asbestos factory, there are lung, they have more, these things involve lung, and they have more likely to have tumor. Now if you are the outcome assessor, and you know that this person is a smoker, or this person works in the asbestos factory, and you are the radiologist looking at the x-ray to determine whether he has lung cancer or not, your preconceived idea will force you to find something. On the other hand, if the person you know that does not smoke and does not work in the asbestos factory, you say, okay, yeah, he does not have, likely he does not have the lung cancer. So you will look at his x-ray film in a very hurried manner. You will not like be very scrupulous. But if that thing happens, then you are introducing your own bias into the study. So in order to prevent that, whoever, if you are the outcome assessor and if you didn't know whether this person is in the intervention group and the control group, you would have given equal importance to their chest x-ray. So that's why outcome assessor must not know the group identity. The same way, patient should not know. Okay, if say for example, you are doing a randomization, you are doing a RCT on physical activity. So one group will be exercising 5 times a day and another group will not be doing that. Now this kind of intervention you cannot hide, because the people who will be doing the exercise know that they're exercising, and the people who are not exercising, they also know that they are not exercising, the other group is exercising. So there are some RCT where you cannot do the blinding of the participants. And what does it do? It creates a psychological imbalance between the two groups. Intervention group thinks that, oh, I'm doing something good, and the control group feel depressed, oh, I'm not getting the benefit. So at the end, if there is a difference in the outcome, say your randomized control trial was about what is the relationship of the physical activity with the development of the diabetes, and you show that the physical activity, the diabetes incidence in the physical activity group is lower than the control group, and you immediately conclude thus physical activity is preventive of the diabetes. You may be true, but it is not, it's not only the, it is not only the exercise, but it's also the psychological boost that the people got from the from the uh, from the fact that they were exercising. So it is both, it is the exercising as well as the psychological boost. So this type of trial is called open label trial, because blinding is not possible. On the other hand, if the intervention was drug, and this drug, the pharmaceutical company tells you that I can make this pill exactly like I will make the two pills. One pill will have the active drug and the other pill will not have the active drug, but both pill will look the same in terms of color, taste, size, everything. You cannot tell which one has the active drug and which does not have. And if you run an experiment here, the intervention group will receive the drug, active drug, but they are thinking that I'm getting the real medicine. On the other hand, the control group is not getting the real drug, but they are also thinking that I'm getting the real drug, because they're blinded. They don't know. It is possible to blind them on the who getting the real treatment and who does not. And so both are psychologically boosted. Okay, so at the end of the day, you find a difference in the outcome. then you can say psychological boost does not make a difference because that both group had the same psychological boost. If since there is a difference in outcome, it must be the active ingredient. So that's why if you can blind the patient, the value of your RCT is higher. If you cannot blind the patient, the value of your RCT is lower. So you want to blind your patient or participant whenever it is possible. You must blind your assessor, and if you can, also blind the investigators. Okay, investigators. So that's why there are many different level of blinding: single, double, triple blinded. So the higher the blinding, better is the quality of the RCT. Now, if the question may ask, if everybody doesn't know, then who will know? Well, in the double blind or the triple blinded study, there is an independent body who will do the randomization, who will do the assignment, everybody. And this information is kept confidential from the participant, from the researcher, and from the assessor. It's a true experiment. As I was talking about the pragmatic trial, this is the term you may encounter, and so that you should know. Pragmatic trial is, as I was telling, that in an experiment, if you can only focus on the people who completed the study, that will be an efficacy trial. But if you look at everybody, whether they completed the study or not, whether they took the drugs or not, and if you look at everybody, then it becomes a pragmatic trial. Pragmatic trials are also that are like community-based trial. Bigger community-based trial are called the pragmatic trial because these are effectiveness trial, not efficacy. Efficacy is like those who are serious, those who are like completes the trial. Another important thing is the ethical issues in RCT. Okay, when should you do an RCT and when you should not do an RCT? Pay attention, very important. If you know the intervention works, is beneficial, you must not do an RCT. Why you are wasting everybody's time if you know that this intervention or this drug is beneficial? Do not do an RCT. If you know that this intervention or the drug is harmful, do not do an RCT. So when do you an RCT? You do an RCT when you have a reason to believe that this drug and this intervention might be beneficial, but you are not sure. That's the concept of equipoise. Okay, that's the concept of equipoise. When you have in an equipoise, do the RCT. You believe from the reading of the literature or from the seeing your patient that this might work, but you are not sure. You need to formally test it. Do an RCT. If you know that something is harmful, you never ever do an RCT on that. That's why you will never find an RCT on smoking. You cannot randomize the two group and ask one group, intervention group, from today you start smoking, and the other group you say don't smoke. Why? Because you will know that smoking is harmful. So if you know something is harmful, you are forbidden to do an RCT. You cannot do RCT on easily on children because children cannot consent. If you want to do a children, you have to take permission from their parents. You cannot easily do an RCT on prison population because prisoners do not have a lot of freedom. If the jail super tells them, hey, you need to enroll into this study, they know that if they don't enroll, their life inside the prison will be hard. So they will be forced to uh, enter into the study, and maybe the intervention is harmful. So you cannot do an easy an intervention RCT with the student, because if I start an RCT here at Suleiman Al Raji and I ask you to participate, you will participate for like thinking that if I go to that, if I do not participate, Dr. Saqib uh, might do something in with my grade, or he will not like me, or he will give me hard time. Out of fear, you may enter into the study. So there are many ethical issues in randomized control trial, from harmful subject to the compromised population. You cannot do the RCT. Okay. Once you do the RCT, I will take another 5 minutes and then we'll end. You need to evaluate the RCT. Is it a valid? How important it is, and what is its application? I have actually talked about all of these things. Now let's put them together. Validity is, when you are assessing validity, you will assess, has the randomization been done properly? Because there are a proper way to do the randomization and there are improper way to do the randomization. Read the method section and see how the randomization was done. If the randomization was done by a computer or a random number table or by a third party, probably randomization was proper. Look at whether the randomization actually work. Where every randomized control trial paper you will read, it is a like a must that the table 1 will give the data between the intervention and the control group. Comparison of between the intervention and the control group is in table 1. Look at whether the two groups are similar. If they're similar, that means randomization worked. If they are not similar and the sample size is small, then maybe randomization didn't work. So this is how you assess validity of randomization. Assess the validity of the blinding. Read the methods, see whether the patients were blinded, or the outcome assessors were blinded, or the investigators are blinded. If you cannot find that information in the trial, it's a red flag for you, that where is the blinding. And you will be amazed when you read the RCT. Many times you will not find that information. So if the blinding is done, it needs to be reported into the randomized control trial paper. So look for it. Look for follow-up. What kind of analysis plan they did? Did they do intention to treat analysis or completer analysis? If they did that intention to treat analysis, thumbs up. Completer analysis, thumbs down. Okay. What percentage of the patients were lost to follow-up? If it is a small, your confidence is high. If RCT has lost a lot of people, your confidence is down. Why? Maybe the intervention drug is harmful. People were experiencing side effect and just quitting the study. So these are the things you will look, that what percentage of the people were lost to follow-up. Are they equal between the intervention and the control group? If they're equal, comparable, you feel okay, it's normal. But if it is unequal, higher loss to follow-up in the intervention group compared to the control group, that should send a red alarm in your head. Okay. And what kind of analysis they did. So you look at this important information in the article and assess the validity. Okay. Look at the effect size. Effect size means like when, like what is the relationship, like how much effect the intervention has done to the outcome. If it is a huge intervention, huge effect, your confidence in the intervention will go up. That, say for example, you find that this drug has cured the patient twice in the rate than the control group or the placebo group, then you know that this drug is very good, because the magnitude of the effect is very high. On the other hand, if you find that the drug had only made a 10% difference or the 5% difference, that's a minuscule difference, and then you need to start thinking, is it worth it? This drug, this costly, this side effect, but only have a slight benefit, 5%. Does that make sense? You can also look at the confidence interval. Maybe in the randomized control trial, they either report in terms of relative risk or hazard ratio. Look at the 95% confidence interval. If the confidence interval includes 1, then you know that this is not a significant effect. Okay, but if it does not conclude 1, then this is a significant effect. So look at two things when you are assessing the importance of that RCT. What is whether the intervention is significant or not. Determine that. And how you determine? Looking at the 95% confidence interval. If it contains 1, not significant, khalas. If does not contain 1, it is significant. And after that, you go to the second step. If it is significant, how significant it is? And then you look at the size, effect size. And if it is huge, you have a high confidence, but if it is low, you have low confidence. So you looked at the randomization, you looked at the blinding, you looked at the follow-up, and now you looked at the effect size. All these you assessed and you are satisfied. So you are satisfied about the validity of the trial. Okay. Number needed to treat is something, it's a very useful measure of validity, and you know that if the effect size is high, then you probably have to like treat only a few people to cure one. So let me explain it in a very simple way. Say you have drug A and drug B. You are comparing and you're doing 2 trials. In the drug A, it shows that if you treat 10 people, you save 1 life. And drug B, you have to treat 100 people to save 1 life. Which one is better? The drug A is better because you are treating fewer people, yet the benefit is higher. Okay, so that's what the number needed to treat calculation is. With that calculation, we understand, is it worth whether the intervention is worth it. If you have to treat thousands of people to save 1 outcome, then you have to think about, is it worth it in terms of money, in terms of effort. I'm spending $500,000 so that 1 person gets cured. Is that? On the other hand, there will be some drug that, for example, antibiotic, you give them like every 2 people, 1 people gets cured. So the rate is much higher. So the number needed to treat is also important. Assessing applicability, the last thing. Maybe the drug is very good. Maybe the trial is very good. Maybe this drug is highly beneficial, but then as a physician you have to ask yourself, does this treatment apply to my patient? Maybe you work in a very poor setting, in a poor country, and this drug is very expensive. Although it works, your patient cannot buy it, so it doesn't apply. Or maybe that drug contains something that your patient will not take. Your patient is a devout Muslim, and this drug has something, an extract from the pork. How can you make him take that, or alcohol in it? So he will not take it because of his religious belief. So even the drug works, it does not apply to your patient population. Or maybe your drug, there is a drug that you have to give, and in the injection form, in a like a private part, and you work in a country where the is very socially conservative. Women will not to the come to the clinic to get that shot from a man. So lot of the things matters. Your patient's financial economic condition, your patient's religious and social values, okay, matters into whether he or she will get the treatment or follow the treatment or not. So RCT, you assess its validity, you assess its importance from the number to treat, and for last you assess the applicability. And once you are happy in the all front, then you know that it's a very good RCT, and the intervention then the drug, whatever it is tested here, it can be used in the population. Okay.
Nice.
So
Okay.
so I took 10 minutes extra. I was supposed to stop at 10 o'clock. But tell me, like, how did the class go?
Very
Because
interesting.
because I am talking at one level, not necessarily taking into account that you are just the beginners. But was it like what percentage of the message did you get, if you have to put a number?
110.
Huh?
110. 110.
Wow.
Yeah. Explosion of information.
Aisha,
Yes, doctor.
what percentage you would put?
I will give it 70 to 80%
Very good.
because it was clear.
Okay. Amir. Amir, I don't know why you log in if you are not here. Ammar, Anna,
60 to 70.
60 to 70. Okay. Okay, fair enough. I think that I like the frankness. If you say that no, I didn't understand more than 20%, I will have to accept it and think about what can I do next time to make it more understandable to the students. Asma, Dana.
Yes, doctor.
Okay, very good. Fatima. Okay. El Tayeb.
Yes, doctor.
So, is this the second time you heard this lecture? I'm talking to one of my fellow, a graduate of SRU, now doing an internship with us, a teaching research internship. So, El Tayeb, did you take
Yes,
it for the
doctor.
second time, or did you hear the first time? Where do you,
No, this is the second time.
this is the second time. And when you were the second year student, did I take this class or someone else took this class?
No, you were giving us this class.
Okay. So, what Is the hearing the second time, did it make any difference?
I think throughout the years, through the cats, it became clearer and easier to understand these topics.
Okay. Okay. I agree with the Al Tayeb, because in the first year and second year, you will learn all of this topic sporadically. But when you come to the third year CAT, that's the building block of research at SRU in the curriculum. We will, CAT 3 is like a boot camp. You come, and by the end, you come out as a finished product. Anyway, I will not take any more time. Do not leave this link. I'm introducing you with two fellow of my wonderful fellow of my, all my fellows are wonderful, wonderful. Abdurrahman Al Farhat and Faisal Al Jubaidi. And I'm here, Dr. Julian Sakib, she's also here. And we will watch and we will intervene, but they will give you the practical. Abdurrahman Farhat,
Yes?
are you ready?
Yeah, I'm ready.
Okay. So do you want to give them a few minutes of break? It's up to you, or you can just start right away, depending. I'm sorry that I took 15 minutes of your time. Please accept my apology.
It is okay. So we will give a few minutes, and also they can talk to the colleagues, inform them that we're starting soon. So perhaps they want to attend, because this practical is actually going to introduce you guys to the assignment, which
Yeah.
will be counted to your block grade, final block grade. So attendance is important. And based on the things that Dr. Saqib discussed with you, it should be easy. Okay.
Okay.
So
So
we'll take
just Dr.
4
Farhat,
minutes.
please tell
Yes.
them the girls and the boys together in this link.
Yeah.
Girls,
All students should attend to the same link given to you guys. This link that we're currently in. Okay. We'll start in 4 minutes. So just a quick break. Okay.
Okay.
See you guys.
Okay. دكتور نظمت or what's the value of randomization?
طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. السلام عليكم ورحمة الله وبركاته. Good morning everyone.
وعليكم السلام. Good morning.
وعليكم السلام ورحمة الله وبركاته.
Okay, so let me introduce yourself. Let me introduce myself. So some of you guys know me already because we've done Skill Lab together 2 times already. For those who don't, I am Abdurrahman Farhat, and my colleague Faisal Zain Zubaidi will be explaining this practical to you guys under the supervision of Dr. Julian and Dr. Nazmus. So we are having our trip program in the college. We are graduate from Al-Rajhi University, and in this trip program, what we are doing is we are teaching assistants and research fellows. Okay, so we will have multiple interactions with you guys throughout the year. Okay, so yeah, let's start. And throughout the presentation, this practical is basically on what have been discussed with Dr. Nazmus just a few minutes ago. So it should be easy. It should be and it should be enjoyable. Okay. So the practical flow. So how are we going to go about this practical? Okay. So first, I'm going to explain what and why are we taking this practical and what is the focus of this practical, and then you're going to read the article supplied. So we've supplied you guys with an article, okay? And there is 2 versions of the article. I will explain them once we're there. And then we'll go through the exercises. And once we are going through the exercises, this is an interactive session. So I'll be asking you questions. Either you can raise hands, and if I don't have hands raised enough, then I will be asking randomly by names, okay? And then we will explain the assignment. Okay, so your assignment is going, we'll explain it today, and you will deliver it later on in this block. Okay, so what and why are we taking this practical? So basically the lecture is a one-way thing. So one is explaining and the audience is listening. Okay, however, the practical is basically more interactive, so you will guys retain the information. Okay, this is why we are taking the practical. And what is this practical about? It's basically about what's been discussed in the lecture. Okay, and the focus of this practical is going to be about the RCT, okay, randomized controlled trials. So we will understand better what's randomized controlled trials. We will try to analyze one randomized controlled trial, and through this analyze process, we will understand the how randomized controlled trials are done, and we will understand how to read them. Okay, how to read them, how to analyze them, and by doing this, guys, you will later understand how to conduct them. Okay, so if you want to conduct something, it's better to understand it first, understand how it works, then you perhaps be able to conduct one of these things. Okay, so that's what we're doing here. Okay, and in understanding RCTs, we will understand the research question, the methodology, the blinding, the phases, and other things as well during this practical. Okay, so are we good so far?
Yes.
Okay, good.
Yes.
So I want you guys now to read the article. So the article is name is combination of isopropyl nitrate and hydrolazine and plaques with heart failure. It's by Anne L. Taylor and colleagues, and it's from the New England Journal. Okay, New England Journal of Medicine. It was published in 2004. Now, as you go through your research rotations, you will know this is a very popular journal, and it's perhaps even the best journal in terms of medicine. Okay, so what I would like you to do now, there are 2 versions of this article. It's already uploaded in the drive, and it's already uploaded in your e-learning. Okay, one of this version is highlighted, so I highlighted the most important things for you guys in this article. Okay, so please Go now. You will have 10 minutes. Read the abstract, specifically the background and method, and read the method section in the article and table 1. Okay, you will have 10 minutes. So it's 10:25. We will carry on 10:35. Okay, so please do read the article now in order for you guys to carry on in this practical. Okay. Would you like me to share the article in the screen?
I think it would be
Yes,
easier.
sure. Yeah, it's correctly fine.
Okay. So this is the article. Have 5 minutes to read the background and methods in the abstract, and then I will move down. Okay.
Okay.
Please, if you finish reading these two, give me a done or something in the chat, so I'll know how many of you guys have read. Okay. So let's interact with each other. Okay. Okay, good. So we have a very good number. That's good. That's good. Okay, so let's move to the next part. It's in the method. So just read these 3 lines. And then if you can read the inclusion and exclusion criteria, just very quick. Because this is an interactive session, so if you have something to say at any point, please just raise your hand and we can discuss things, okay? Okay. Well done, guys. You've done the reading part in 5 minutes, and then that's very good. Okay. Let's carry on then. So the first exercise is try to formulate the research question. So I want to ask someone, how do we formulate any research question? Can I see some hands? It's already in front of you guys. You can, yeah, please, Aisha, go ahead. So what are the part of research question? How do you formulate one? What are the components?
Okay, so first of all, we need to know who are the population we are going to do the study on. Second, the intervention as it written here. Then we will compare between our result. We'll see after that the outcome. Has the trial been a good to be proceed or not?
Okay, so Aisha, stay with me. I'm gonna discuss this exercise with you since you've
Okay.
started already. Okay, so that's good. So you mentioned any research question has 4 components. Okay, so your population. Okay, and then that should be included in your research question, and then the intervention that you're providing. Okay, and the comparison. So what we mean by the comparison is that how are we comparing this what are we comparing this intervention to? Okay, so is it a placebo? Is it another kind of treatment? Is it a standard treatment or whatever? Okay, so that's what we mean by the comparison. And then the outcome is it's like, how are we measuring how successful our intervention is? This is what we call the outcome measurement, or measuring the outcome. Okay, so very good, very good. Now, if I ask you to form the 4 components from the article. So I've tried to help you here a little bit. So I have the methods in front of you. Have the method in front of you, and it's
Yes.
also highlighted. Okay, so try to take each component from the method and tell us where you would like to put that in the BICO components. Okay, so go ahead.
So the first one, which is the population, are the Black patient who had New York Heart Association class 3 or 4 heart failure.
Okay, good.
For the intervention, we have fixed dose of isosorbide dinitrate plus hydralazine or placebo. This is for the blinding. And in addition, standard therapy. For the comparison, we'll see, for the result. And then for the outcome, wait. The primary endpoint was a compensate score.
Okay. Okay, so you've done very well there. You've done very well. The population is Black patients who have heart failure. Good. I totally agree. In the intervention, it is the fixed dose medication in addition to standard therapy. However, here's the trick. Okay, so the comparison, we're comparing this intervention to the placebo. Okay, so the intervention is a fixed dose of isopropyl plus hydralazine, and the comparison is placebo. Okay, so here's the thing. That's why I highlighted placebo in green, because it's the comparison. We're comparing intervention group to placebo group. Okay, and both the group will receive what? Will receive standard therapy. Okay, so one group will receive fixed dose of isopropyl nitrate plus hydralazine in addition to standard therapy. The other group will receive placebo in addition to standard therapy. And the outcome here is what? Exactly what you said, the primary endpoint. That's correct. It's the primary endpoint, which is a composite score. And just to make things easier, we're going to say that the outcome here is also, one of the outcomes is death. Okay, so we're going to follow up the patient, see in the 10 years, the mortality rate. Okay, so very good, very good. Now, if I ask you one more question, Aisha. So
Yes.
why are we giving additional, why we are giving this treatment as an additional treatment? So each group will be taking standard therapy, right? In addition, one will take the intervention, which is the isosorbide nitrate, and one will take the placebo. So why are we giving this treatment in addition? Perhaps it's better to see the exact effect just to only give the intervention and the placebo, the medication and placebo. So why we are giving in addition to standard therapy? Any idea?
Maybe to keep in their status stable. We do not want to harm the patient.
Exactly. So that's one of the things. That's one of the ethics and RCT. Perhaps as a researcher, you would like to see the exact effect of this medication on some disease. But however, you can't do that because there are ethics. There are the research ethics. So that's why if you have to do things, you have to do it in additional to things and other things. For example, here giving the standard therapy. Okay, so we don't want to harm the patients. Very good. Very good. Thank you, Aisha. Okay, so that was...
Farhat, I would just like to add something regarding the outcome. Do you hear me? Yeah. You mentioned that the outcome was the composite score, right? I would say we better say that the outcome is death from any cause, or first hospitalization for heart failure, or change in the quality of life. These three elements better reflect the outcome, because the composite score was the thing that was used to measure these three outcomes. That's it.
Thank you, Mohammed Abdelazim. Mohammed Abdelazim is one of our colleagues. He's also a fellow with us in the TRIP program. Well done, Abdelazim. We'll talk about the outcomes more when we come to the exercise related to it, but thanks for the addition, okay? Exercise 2. What's randomization? So I'm gonna need another one from the group to go with me through this exercise. Anyone as a dean, please go ahead. So if I ask you based on what you've discussed, what Dr. Nismus discussed with you guys in the lecture, so what's randomization? Simple
I
question.
think, yeah, it's the process by which I will assign the individuals into two groups: the intervention and the other group, control group.
Correct. So it's a procedure in which population and randomized control trial are distributed into groups, and you have to include the word randomly, randomly distributed into the groups. Okay. Does it have to be two groups all the time?
Not necessarily, depends on the study design.
Exactly. So you could have more than one group. Okay, 2 groups, 3 groups, 4 groups, or whatever. Good. So what's the purpose of randomization, Izzuddin?
If we achieve a better randomization, then the results will be able to represent the population. The study will be able to represent the population. There is no bias. Yeah, it's validity.
Good. Let me paraphrase the question. So by randomizing the population, what are you trying to prove or exclude before starting your study?
Yeah, I think most importantly, we are trying to control the confounding variables.
Exactly. So when you are randomizing the groups, you want to make sure that your groups. So when you start a study, and for example, if it's an RCT and you're starting a study, you have 2 groups. In the very beginning, we call that baseline, okay? And then you start giving the intervention, and for example, the other group, placebo, and you continue on. We call that follow-up, okay? So at the very beginning, at your baseline, you do randomization, and you make sure that you try, by randomization, you're trying to say that the confounders and my population, I have randomly assigned them to 2 groups, so there will be no difference between the groups at baseline. You get my point?
Yeah.
Okay, so that's what you're trying to say, okay? And And we also call that if you have, because sometimes there are a lot of things that play role and for example treatment or whatever. So you don't know the things that play role. Okay, so what you're trying to do is that all known and unknown prognostic variables, okay, are similarly distributed into the groups. Okay, good. So if I ask you to mention several methods that can be used to randomize patient, or before doing that, so this is what we're trying to do by randomization. So you have 100 patients, okay, and recruited in your study. You're going to conduct the study in 100 patients. So you randomly assign them into two groups. That's what's randomization. Okay. Now, if you as a dean can read out the slide and just tell me what you understand from whatever is written there.
It's different mechanisms by which I can do randomization.
Okay. Okay. So, for example, one of the method is that you go to a neutral party and you ask them to randomly assign numbers, for example, into two groups. Other way is what we call a central randomization office. So there are central randomization office that can distribute population into groups. There are generators, okay? There are websites. You can simply toss a coin. So you can say, if I get a writing, it will go to group 1. If I get a face, it will go to group 2, okay? Or you can have a list with random numbers. All of these is a way of, are methods of randomization, okay? So if I ask you guys, how were the randomization done in the study? Azzuddin, can you figure that out? Can you open the study and try to figure out how was the randomization done in the study? Okay, so I have it here. So if you read that out loud and tell us, what do you think?
Yeah, the randomization was performed centrally by the Medifact International.
Okay.
So they use the central office.
Exactly. So they used an office or a company to do the randomization for them. Good. Good. Thank you, Azzuddin. Thank you, Azzuddin. So who's gonna be with me next? Anyone? I'm gonna pick names randomly by randomization. Okay, Rakan.
Yes. Before we start the next exercise, can I ask you something about the coin toss randomization?
Tossing a coin, yes.
Yeah, like when I toss the coin, should I take two names and I will like choose one of them to get heads and go to something? And like when I take 100 patients, will I have 50 coin tosses?
You mean divide 2 by 2 in order to have equal number in each group? Well,
Yes.
it doesn't have to be this way. Tossing a coin is one of the simplest method ever to randomize. It's just a way to say that this way we can randomize. However, it can be used, but it can be used either way, and at least that's what I think. Dr. Nazmus or Dr. Zidan can correct me. It can be used either way, but you can use them as one by one, and even if you end up with one group more than the other, that's your randomization process. Okay.
Okay.
Okay. So exercise 3. What are types of treatment studies? It was explained in the very beginning of Dr. Nazmus' lecture. So what do you think?
The treatment studies, I believe, like, are we talking about the trials or are we talking about?
Okay, so
pills?
one of them is clinical trials in general. Okay, and under clinical trial falls what we call the randomized control trial. That's correct. So one of the treatment study or interventional study is clinical trials, and then the other one is what? What Doctor explained is
The randomizations, like treatment of randomization, or like exactly what we read right now. Taking people who identified as black and checking if their genetics affected the efficacy of the dinitride hydroxylene.
Okay, so good. This study is what is a randomized control trial. It falls under the category of clinical trial. Okay, so one of the interventional studies or treatment studies is the clinical trial, and randomized control trial. It's the same thing. Okay, that's one. And then we have, on the other hand, is the observational studies. Okay, the observational studies. So although it's a treatment study, it's basically you're testing some kind of a treatment or a therapy. However, it works by observation. You're not giving. For example, you will have two groups. One of them is taking one medication, other is not. But that's the original status. Okay, that's the original management plan, and you're comparing both groups. You're not actively intervening by giving one medication and the other group other medication or placebo. Do you understand me here?
Yes.
Okay, good. So we said observational studies. What's an observational studies? I explained it in a way just now, but what kind of observational studies do you guys know? What kind of observational studies do you know, Rakan?
Yes, for example, seeing if how the treatment exactly, like saying, for example, if this drug will work on pregnant women or not, or how efficient it is, like the folic acid thing. We'll observe if the folic acid will cause more stillbirths or not.
Okay, so
Right.
it's correct. What you're doing is you're explaining the studies. The names of the observational studies can be, for example, case control study. Good, Dana. Cohort studies.
Cohort,
Okay.
yes.
And what we have one more. Case control, cohort, and cross-sectional.
Cross-sectional.
Yes, very good, guys. Very good, Rakan. Okay. So that's observation studies that you try to explain. Okay, good. So this is just a quick reminder of what was been discussed. So why do we use observational studies? So basically, let me paraphrase the question for you. We have clinical trials or randomized clinical trials. We know it's the best, that's for sure. But we have observational studies, and sometimes we do use observational studies. Why? If we have clinical trials, it's better. Why do we use observational studies? Harakan, what do you think?
Maybe to have an idea of exactly to assess the situation before we start an actual treatment plan.
Okay.
Or a treatment study or a clinical trial.
Could be. Can you read out from the messages? Some of the answers
less
are there.
time, less money.
Exactly.
Create a hypothesis, a theory.
And easier. So all of these are reasons why we want to conduct observational studies. We not all, let's say, researcher or clinician are able to conduct clinical trials, and the ethics of conducting clinical trials are a bit challenging. So observational studies tend to be sometimes easier to conduct. Okay, it costs less. It costs less time and less money. Very well. Okay. And if I ask you why we do RCT, if we have all of these in observational studies, why do we do RCTs?
To prevent any bias.
Okay.
And to, as the dean said, to make it like go on the population, fit on the population. Our theory should always fit on the population.
Exactly.
And
what
the
I
closest thing we could, yeah.
You continue,
yeah,
carry on.
Sorry.
No, carry on.
Yeah, I mean, like that's the best thing, like to plan it on the population. That's
exactly. I like how you're trying to explain things. So we do RCT because it falls as the top of the in the top of what we call the evidence-based medicine. Okay, so when we talk about evidence-based medicine, one of the studies or evidences that we use are clinical trials. It's even above all the observational studies. And what comes above that? It's the gold standard. Yeah. What comes above that? What we call is systematic review and meta-analysis. Okay, that's just an extra information for you guys. Okay, so that's the advantage of RCT and observational study. Thank you, Rakan. Thank you very much.
Thank you.
Okay. Who's gonna with me next? Who's gonna be with me? Any hands, or I will choose. Okay, let me see. Sida Zainab Farouk, can you unmute yourself? That was choosing randomly, okay? As we're taking a randomized control type, that was choosing randomly. Yeah, can you be with me in this exercise?
Yeah, sure.
Okay, good. Okay, so what are the exclusion and inclusion criteria? What do you know about exclusion and inclusion? What are these? Okay, and what is the difference between them? Just tell me, what do you think?
It's kind of like the criteria that like we use to, for example, like the criteria that we use for to know that which are the people or which is the group of population that like we have to include and which are the ones that we don't have to include.
Exactly. Okay, so it's a criteria that the researchers implement to know who's gonna join and who's not. Okay. So for example, if I say one of my inclusion criteria, and it has an explanation or it has a meaning, but we'll come to that. So for example, I want to conduct a study, and in that study, I want only people above 18 years to be included. So one of my inclusion criteria is what? To be
That you should
above
be above 18
18.
years. Yeah.
Good. That's one thing. Okay. So let me give you another inclusion criteria. Another inclusion criteria I would like to have is, for example, or let me tell you one exclusion criteria. One of the exclusion criteria I would like to be is that people who have more than one comorbidities. Okay.
Yeah.
So that would be anyone above 18, but if they have one more than comorbidities, then they will be excluded. Okay. So that's inclusion and that's exclusion criteria. Now, if I just, yeah. Okay. So why do we use them? Why do we use inclusion and exclusion criteria? What do you think, Sayyida Zainab?
I think because we use the inclusion and exclusion criteria so that we know that do we need to perform the study or we don't need to perform the study.
What do you mean by do we need to perform or not performing the study?
What I mean to say is that, for example, like we said before, there is the inclusion and exclusion criteria. So there has to be some parameters on which we decide that, okay, we perform the study on this type of person. For example, if we take an age group that it's 18 years old, but apart from that, we're gonna make some more parameters. For example, as you mentioned before about comorbidities or some other.
Yeah, carry on.
Yeah. So it's like 2 to 3 parameters. Like this is what I mean by performing study.
Okay. So, well, what you said and large terms was actually correct. So we use parameters to try to make our study, let's
Valid.
say,
Yeah.
What we're trying to do is we're trying to have internal validity of the study. Okay, so sometimes, how to say it? So, for example, if for example, with the one I just told you about, the exclusion criteria of more than one comorbidities. So if I
Yes.
have patients who have more than one comorbidity, and for example, my outcome, what I'm measuring is, for example, mortality rate in 10 years. Having more than one comorbidity sometimes can increase the mortality rate and therefore disturb my measurement of the outcome. Okay, so what I want to be focused is just, for example, the thing that I'm studying. Okay, that's one of the things. That's why we use exclusion and inclusion criteria. Okay,
Mhm.
so if I ask you, what are the inclusion criteria in the study? So you have it in front of you. This is the inclusion. So if you can read them out loud for us.
So there are patients which are 18 years of age or older, and
Okay.
they should be self-identified as Black, which is of African descent.
Okay.
And they should have NYHA class 3 or 4 heart failure for at least 3 months, and they were eligible for screening. Okay.
Okay.
And they have been required to be receiving standard therapy, and also had to have the evidence of the left ventricle dysfunction.
Okay. So these the inclusion criteria that were used in the article, and these are the exclusions. So if you can read them for us out loud again.
Okay. Women are excluded if they were pregnant, nursing, or of childbearing age and not using an effective method of contraception. Also, an acute myocardial infarction, acute coronary syndrome, or stroke within the preceding 3 months, the presence of clinically significant valvular heart disease, history of cardiac arrest, or life-threatening arrhythmias within the preceding 3 months, the presence of symptomatic hypotension, the presence of an illness other than heart failure.
Okay, good. So well done. That these were the inclusion and exclusion criteria in that study. And for example, I've already explained, or let's analyze one inclusion and exclusion criteria. So one of the inclusion criteria was self-identified as Black. So what are the researchers trying to do by having this inclusion criteria? What are the advantages and disadvantages of this inclusion criteria?
Maybe the effectiveness of, the medicine or the drug that we give.
Okay, so you
Or
want
it
to
will.
have similar groups, all Black. Okay, that's what we call homogeneous group. Okay, both of them are similar, for example, in terms of race. Okay, that's one of the advantage. Okay, good. And if you have homogeneous group, if you have similar groups, then it's easier to distinguish the treatment effect from being a coincidence or a chance. Okay, what we call is easier to distinguish the signal from the noise. So if you have, for example, a lot of different races, and that what we call noise, for example. Okay, and in noise, it's difficult to differentiate to differentiate or to distinguish the signal. That what we mean by the signal is the treatment effect. Okay, well done. That's the advantages. What are the disadvantages?
Maybe for example, if we just have one type of group, there even might be some people who would not have the correct effect of that particular treatment.
Interesting. Well, one of the most important disadvantage here, Sayyidah Zainab, is that when you finish your study and you come up with a result and you say, for example, this medication will decrease the mortality rate by 50%, for example, okay? And we ask you, who were your population, so we know on whom exactly this medication will work. And you say, my population were from all ages, from all kind of male and female, from all genders, but they were only black. So as a clinician, I will be asking this question: would this medication actually work on white people or other races? Okay, so you understand me here. Yeah.
Yes.
So the disadvantage sometimes of having too many inclusion and exclusion criteria is that questions will be asked: is this kind of management will be applicable to all people, or it's only for the population that were used in that study? So what we call the generalizability. Okay, the generalizability might be decreased. Okay, or or what we call also external validity. So we have internal validity and external validity. External validity sometimes is lower if you use too many inclusion and exclusion criteria. Okay, so thank you, Sayyidah Zainab. Let's go to exercise 5. And who's gonna would be next? Who's gonna be with me? Any hands?
Doctor, could you please give an example of the internal and external validity?
Internal validity, it was explained by Dr. Nazmus in the presentation, and it's composed by what we call the randomization, blinding, and follow-up. Let's do questions at the end of the session. So we will focus now on the exercise, try to finish. So you guys, and give you the assignment, and then perhaps can go into details of question. Okay. So
Yes.
anyone is volunteering to be with me in exercise 5? It should be an easy one, right? Yeah, it should. Okay, so I will be randomly allocating one. صالح المسند.
Yes, doctor.
Welcome, Saleh. So are you ready to be with me for exercise 5?
Yeah, sure.
Good. Okay, so the first question in exercise 5, what is the reason for using a placebo in RCT?
I think to prevent any misleading information, because some patient may like some patient may like in Arabic I'd say like يمثلون إنهم عندهم أعراض.
Exactly. Yeah, exactly. So can you try to say that in English?
I think though I lost the word, doctor. Sorry.
Okay, so what Saleh was trying to say is that placebo will prevent some assumptions or some pretending. Okay, that's what Saleh is trying to say. And what we call this in epidemiology or research, we call that bias. Okay, so for example, if you have two persons, you give someone one medication, and the other one you don't give him anything. So the other one will say that I'm not being given anything, I'm not taking anything, therefore he's expecting himself to worsen. Okay, so that sometimes that's not true. Okay, sometimes that's not true. So the assumption or what we call the bias, by knowing that you're not being given an intervention, okay, or even sometimes if you give someone a medication, and let's say that medication or that intervention is not very effective, however, because you're giving something to someone, that someone will think he's getting better. And for example, if you ask him after a few weeks, how are you doing? He would say, oh, I'm very good, doctor. Thank you very much for the intervention. And the intervention was nothing. The intervention was actually, it's nothing. So this sometimes can be psychological effect rather than actual effect from the intervention or from the medication. Okay, good. So if I ask you, Saleh, a good placebo has to meet standards. Can you think of any? So let's say I'm giving you, and I'm helping you now, okay? Let's say I'm giving you a medication that is circle in shape, red in color, and it's very small in size. So what do you think the placebo should look like?
Exactly the same as this one.
Exactly the same. That's what I'm trying to say. That's the standards that the placebo should meet. Okay, so that's the, and why is that? Do you can you think of any reason why is that?
Yeah, because the patient may be able to differentiate which one is the placebo. Maybe
Exactly.
they will talk with each other, or maybe something like this.
Exactly. So exactly, that's what I'm trying to say. Okay, so this is actually a very amazing figure if you understand it. So let's say you have on the right what we call is the natural course. Okay, so let's say at point zero we have three people. Okay, three persons, and one we call natural course. We will give him nothing. The other one will give him placebo, and the last one will give him intervention, a medication. Okay, so if all of them has disease at point zero, okay, so point zero is a disease, and we follow them up. The one who with natural course, let's say he improved by 20%, okay, on its own, he's improving on his own. The one with the placebo or the one with the intervention will be improving the most. He improved by 60%. Yeah, because we're giving him medication. But you can see that the one with the placebo is actually improving by 40%. And why is that? He's taking placebo. The placebo means he's taking nothing. He's taking just a dummy pill or something. Why he's improving by 40%, although the one with nothing is improving by only 20%. Why do you think is that, Saleh?
I think it's maybe psychological.
It could be psychological. It's mostly psychological, actually. Yes. Well, that's correct. So evidence have shown if you give placebo sometimes, then it's not people that will improve. It's rather the intervention or the medication that you're giving to the intervention to the other group will not be as effective as if you're not giving placebo. Do you get my point here? يعني اذا اعطينا واحد اذا اعطينا عندنا تو ستديز. اوكي، الستدي الاولى اعطينا واحد دواء والثاني ما اعطيناه شيء. لقينا انه الدواء حسن من نسبة الشخص مثلا كان ممتاز بنسبة 60%. لو اعطينا الاول بلاسيبو، لو اعطيناه دواء عادي لعبة يعني ما هو دواء حقيقي، مويه خلينا نقول، لقينا انه الفرق بين الاثنين ما هو 40%، الفرق بين الاثنين 20% بس. فانا هنا اعرف انه الeffectiveness for the intervention is actually not 40%, is only 20%. Okay, so it affects the study and the result. تمام. And again, here's the standards of a good placebo. It has to be matched in color, labeling, size, and same quantity and frequency. Okay, good. So I will be stopping here. My colleague Faisal Zain Zubaydi will be with you guys from exercise 6 up to 10. And then we will explain the assignment for you guys and you will be set free. So thank you guys for being with me. I really enjoyed talking to you, talking to all of you, especially those who participated. And we will explain the assignment. So do not leave. We will explain the assignment at the end. I'm going to answer just the last question. So eventually we'll stop giving them the placebo. You will give the placebo and the intervention as long as you're conducting the study, Dana. So if you're conducting the study for 1 year, then you'll give the placebo as long as you're giving the intervention or the medication, the real medication. Okay. So if I stop sharing now, Faisal, can you share slides from your side?
Assalamu alaikum. Is the slides are visible for you guys?
Yeah, they are.
Okay. Okay, just give me a minute. Okay, assalamu alaikum wa rahmatullahi wa barakatuh. My name is Faisal Zubaydi. I'll be with you from exercise 6 and on. I hope that you didn't lose your energy so far. So, any volunteer for the exercise 6?
There is one volunteer if you can see in the participant.
Okay, Nada.
Yes.
Okay, Nada. So we are talking now about blinding. Who you think you can blind when you are conducting a study?
We can blind the participant and the sample, and also sometimes we can the researcher himself can be blinded.
So by the researcher, you mean the one who will conduct the study or the one who will assist the patient or analyze the data eventually?
I think the researcher will conduct the one who will give the placebo and the intervention.
So it can be on a multiple level, like the researcher committee, there is the one who will allocate the patient, and there is then the one who will take the data from them, obtaining them, so whether it's objectively or subjectively. And finally, the one who will analyze the data once they have it, all of them. So it can be on multiple level other than the patient themselves. So if we say the patient, how we can blind the patient or what we can hide from them?
When giving them the placebo, this means blinding them.
So you mean they don't know whether they are taking the medication or the placebo?
Yes.
Okay, and this is like a comprehensively, in a comprehensive manner explained by Dr. Farhat in the previous slide. What about if we are going to blind the assessor that they shouldn't know, the one who obtained the data from the patient while we are following them up?
Could you repeat the question?
What about the assessors, the one who obtained the data from the patients, whether they are located in the placebo group or the treatment group? So what information should we hide from this assessor so he can be blinded?
The information we should hide that which this group is taking the intervention or placebo. So they should like taking the information from them without know what are they taking.
Okay, that's correct. So, and eventually, why the fuss? Why we start with the blinding in the first place?
To avoid bias and avoid like pretending symptoms.
Yeah, so the patient may take the symptoms, and what about the assessor?
Because like the assessor might think they are taking the intervention, so they will be better and they will be like يعني when the assessor knows, who will like expect the result.
Yeah, exactly. This is what's called assessor bias. So the assessor will seek the results of the intervention. He will try to find something that's enhancing or worsening in the patient. So they will keep a closer eye than the placebo group to find those changes in the outcome. So and eventually we'll talk about our study. But before that, so first of all, we have our sample population. And from the sampling process, when we take a sample from the population, we will have to select certain sample, and the sample then will be divided into two groups. So when we select the patient, at which level we are talking about in here? So which level we should blind? Who should be blinded in this level in the selection process? Dana?
Yes, doctor.
Yeah. We have a pool of population. Let's say we have 1,000 persons. Then we have to select 100 and divide them into two groups, the one taking the placebo and the one who's taking the real actual treatment. So at this level, the first level in here, who should be blinded and why?
After dividing the population or the sample we took, I think the patients or the participants should be blinded, so as the one giving them the medication.
So the patient will eventually be blinded in the second step, but in the first step, the one we want to blind specifically is the allocation. Let's say the allocation institution or the whoever gonna put the patient in the first two groups. So as Dr. Najm mentioned in his lecture, that like if the person who is entitled to allocate the patient knows the patient, a family or a kin or a friend, so he will put him eventually in the arm which received the treatment, and we will end up with bias. So by taking a third party department or institution or a company who will allocate the patient for us, we will end up with less biased group. So here we talk about the allocation. And the secondly, as you mentioned, that the group themselves, the patient should be blinded, whether they are receiving placebo or if they are receiving the real treatment. What about the third step? Who should we blind? We've discussed it like before 3 or 4 minutes.
Who given the medication and who's analyzing the information on the state of the patients?
Yeah, the one who will assess the patient, the doctors or GPs that are going to follow up the patient, they should be blinded and don't know which arm the patient are assigned in. And eventually, when it comes to outcomes, who's the one going to be blinded in here?
Who's analyzing the information?
Yeah, exactly, the analyst. The analyst who going to deal with the data should be blinded, so he is not going to seek any changes, or he tilt his way of analyzing the data to find an outcome supporting his argument.
So if we're blinding who is making the groups and the patients and the clinicals and who's analyzing the information, who knows what groups is taking the placebo?
So the research conductor, the one who is going to follow up the research, he's in a different institution. He wants to find this data, but when he wants to do every step of this of his research, he will assign another party, another institution to deal with those steps. So he only end up with the analyzed data and then writes his manuscript. So he has zero influence on those data.
So he's just observing the whole process?
Yeah, he will finally see how his hypotheses were followed. So let's say you will want to conduct an research and you are an SRU student, then you will deal with King Saud and Riyadh to do those steps, and then they will hand you over the data to see how those findings or your hypotheses were followed.
Okay, thank you.
Okay, welcome. So in this study, you can read those 2 lines.
Doctor?
Dana, you can read those 3 lines.
Okay, so who have been blinded during this study? The African American heart failure trial was a randomized placebo-controlled double-blind trial with patients recruited at 161 centers.
Okay, so this kind of trial was double-blinded. When we say double-blinded, it's mainly mean if it's single-blinded, only the patient. If it's double-blinded, then the patient and the clinician. And if it's triple-blinded, then the analysis will be added. Okay.
Okay.
So exercise 7. Anyone want to volunteer for exercise 7? Or should I pick? Muhammad الطيب. He left. Okay. عمار العمر. Or عمار العمار. عبد الله بيطار. Okay, Azzuddin. It's fine if someone like participated previously.
Yes, Doctor.
Okay, Azzuddin.
Yes.
In this study, which outcomes measures they have been following, as you were reading the article?
Yeah. So is this question asking for how did they like analyze the outcome?
Yeah, the measures, the outcome they use to assess the progression or the failure of those patients into the study. How do they follow them up?
Yeah. I think they did. The outcome measures mentioned in the study is primary efficacy endpoint for the trial was a composite score for death, first hospitalization, and change in the quality of life. 3 factors. Yeah.
So the composite score is made up of the other points, but the primary endpoint or the answers for the primary question were meant for the death and the change in the quality of life.
Yes.
So in here we can see in the table for the primary endpoint they followed the death, and if the patient died they would score him with -3, and if the patient survived to the end of the trial they would score him in 0, and so on and so forth. So we have mainly two things: the death and the quality of life. What do you think the advantages and the disadvantages of each of those two? Let's start with death. What do you think? Why do you think this is like a strong point to being followed? And what do you think if there is any disadvantages?
Could you paraphrase the question again?
So they picked death as a measure for this study. Do you think this is like a solid measure? Is it good? What are the advantages of selecting death? Or do you think it's bad? And what are the disadvantages?
I guess choosing death as one of the measures is good.
And do you have any idea why it's that? Or any one of the group they can write in the text box. That's fine.
So
maybe it's
I think
go ahead.
I think death is a very severe result for a study. So we have to have as many groups or a variety of results before death. So if we are aiming for the patient not to die, I mean that's pretty tough, isn't it? So we are looking for a good results, but at the same time we're not hoping for the death of the patient or any other consequences of the drug we're experimenting.
Mm-hmm. So death is a good predictor for like long-term benefit of this medication. Like if you are assessing them on the run of 5 years or interval of 10 years. So this will be a very good assessing point. But also in here they mentioned the first hospitalization in the hospital. Did they have to be admitted? Have their case been worsened? So the death is good and solid, but it's good for the long-term run. Also, it's less sensitive for any other, let's say, distortion or any other external factors. So the patient, if the patient knew that he is taking the placebo, he cannot fake his death. So this will be a very solid point to prove in the research. And it's objective. So the patient has nothing to do with this. We can assess the patient. If the patient has died, this is very clinical point of view. But if we take the change in quality of life, on the other hand, what do you think? What are the advantages and what are the disadvantages? Taking into consideration the point that we mentioned in the death. Dana?
I'm sorry, can you say the question again, please?
Yeah, we discussed the death as an endpoint goal for this research, and now we want to talk about the change in quality of life. Taking into consideration the point that we said it's good or bad about death as a measurement point, what do you think the things, the bad or good things about the change in quality of life as a measurement?
Like what's going to change in our patients' life, in their quality of life?
Yeah, this is what we are going to follow up, but what do you think is good about that?
They're like, of course, their quality of life should be better, like become better after we gave them the drug we're testing. But if their quality of life became worse because of the complications of what we're giving them, that would be a bad result of our experiment.
So, and the quality of life, the assessing, as we saw in the previous slide, it was based on the patient reports. It's like we give them a survey and they fill it out. So what do you think? This is an objective or subjective measure? Nada? The question is for the whole group. Izzuddin, Nada, anyone else want to participate? Do you think that when we give a patient survey, is that a subjective or objective measure?
Definitely subjective.
It is subjective, so it's prone for mistakes. So we only relying on the patient answers. It's also very sensitive for bias. If the patient know that they are taking the medication, they will answer, most likely they will answer as this is they are improving. And if they know if they are in the placebo arm, they will tend to report the same like symptoms they used to have prior to the intervention.
Nice.
Okay, now for exercise 8, who want to participate?
I can.
Abdul Waris, can you please be with me in this exercise?
Yes.
Okay, so for exercise 8, what are the 4 phases of research in humans? Do you know them? It's mentioned in the lecture by Dr. Najm.
Not really.
Sorry, what have you said? So anyone knows the 4 phases? Okay, Fatima, you can open your mic and share.
It's select the population. This is first phase. Second, which is allocation of study, right?
This is more of the steps we take in each phase of the trials. But okay, so when we're conducting a research on a human, we have to start prior to that by doing the same interventions on animals, as Dr. Najm said, because it's more controllable and it doesn't have the ethical dilemmas that we have to face when we are dealing with humans. So for the phase 1 trials, we are conducting those on human subjects who are not having any diseases. So the results will be clearer and clean. And we do this in a minimum number. So we have only 40 to 50 patients. We have to test the toxicity of this drug and the effective dose. We're starting with 10 milligram, 20, 40, until we reach the dose that's effective and going to change the patient status. When we are testing on the phase 2, we will have like a larger group of population, and we will start the efficacy of this drug. So we will introducing ill patients disease who have certain disease that we want to experiment on, and we will give them the medication. The difference in here, we will still have a smaller population, and we cannot apply this on the whole population. So we cannot generalize our outcome. We will have this in very strict and ideal conditions. We'll have 100 patients, for example, and we will follow up them closely, and we will minimize the co-founders that can affect on our outcomes. When we come to phase 3, we want to test the effectiveness, not the efficacy. The efficacy is the thing that we have as an outcome in the ideal condition. But the effectiveness, this is what we will see in our daily life. If we give this, if we give patient 1 a drug and patient 2 the same drug, it will act differently because they have different lifestyle and different diet and different medication and different diseases as a comorbidity. So in phase 3, we will try to generalize our outcome when we have it. So we will have a bigger group, a bigger population, bigger sample, and a very different and variable sample in each arm. So when we have the outcomes, we can generalize it over the population. So according to those phases, what do you think this article, in which phase, this study?
In phase 2 and 3, maybe?
You think it's in phase 3?
2 and 3, because we are testing the efficacy and the effectiveness. So we start to know first, before this, we said we're testing like the clinical trial itself on the animal. Then we are starting with a small group of people, like you said, 40 to 50. So this is second phase. And for the third phase, we are enlarging the population or the sample itself to know more about the effectiveness. So it would be in phase 2 and 3, if I'm not wrong.
So it says this phase, it's a phase 3. So we are trying to find if this medication is applicable to be served for all the Black people who suffer from heart failure. So we are comparing 2 arms, one with the placebo and one with the medication we have, and see if this is gonna help them on the short term and the long term as well. Okay. So for exercise 9, any volunteer? I think this one should be easy because it's thoroughly discussed in the lecture. We only need a couple of examples. Anyone? Those have a problem in mic, they can write in the text box. Aisha,
Yes.
so can you give me an example when we cannot have an RCT?
What does it mean, visible? Feasible, to start with?
Like applicable, we cannot do the RCT.
When it's about smoking, or as you said in the unit, people, children, we cannot do it on people.
So when we talk about children, so it's very difficult because we have to obtain the consent from their guardians, but it's not like 100% we cannot do this. But this example of smoking, like you gave an example, but what do you think? Smoking as an example, but what do you think the bigger idea of we cannot doing smoking RCT? Fatma, you can answer.
I think if there any harm for people.
Exactly. We cannot harm people. We cannot give them a study based on smoking, using of drug, or any other thing that we can consider illegal or unethical in the practice. What do you think that if we want to conduct a study about a very rare genetic disease, can we do an RCT?
No.
Because of?
We might have mutation in the new generation, and this is illegal.
No, we are not going to induce a genetic disease. Those people already have a genetic disorder, but we want to compare the efficacy of two medication on them. Why do you think it's hard to be done? Like, why we cannot do those RCTs?
We cannot control people.
We cannot have enough samples in the beginning. We might need huge resources and funding to have multiple centers to obtain only 100 patients, for example, because it's very rare mutation or rare genetic disease. Okay, what else? Any other ideas? We were talking about medication. What if it's not medication, it's another intervention? Let's say we have a study, we want one arm or one group to do vigorous exercises for half an hour, and the other group not to have those kind of exercises. What difficulty you will face when we're doing this RCT?
I think it's hard to control the placebo because groups who are not exercising will know that they are the control group.
Brilliant answer, because you are going to sign them a paper for consent that you are in study for the benefit of a physiotherapy or of doing exercise, but you will ask him to do nothing. So it's hard to be blinded. It's also hard to follow up with those who in the interventional art. You cannot force the people or exactly follow them up how they are performing those exercises and if they are doing it for enough or a long time. So you will encounter some difficulties. It's doable, but it's very hard to do. Okay, finally the last question, the last exercise. It's exercise 10. So I think when I asked about the phases, Fatma mentioned something about selecting the population at first. Fatma, was it you? Or so I want anyone to give me the steps of conducting a research or RCT. What should we start with?
Choosing the sample.
Okay, so we have to define our population and pick our samples, correct?
Then allocation.
What's next? So in this study, you can read from the screen. So in this study, what they did to obtain their population and sample. Can you read, Fatma, please, from the flow chart?
Okay. Screening patient over than 18 years, self-identified Black, NY class 3, and IV for more 3 months.
So in this case, you define your inclusion and exclusion criteria, right? You first start by inclusion criteria, then you exclude the others who have they like met the exclusion criteria, and you will end up with your sample or study population. Okay, then you will do what will you do as a next step after you obtaining your sample?
Follow up.
Before you now you have 100 and like 1100 people or persons in your hand. What should you do before you go to the follow-up? Don't you think that you have to divide them?
Give them the treatment or the placebo.
Yeah, so you have to divide them whether they will go to the placebo group or to the interventional group. So in this particular scenario, the intervention group will have isosulfide, dinitrate, and hydralazine. And for the control group, we will give them placebo. And the outcome will be similar for both death, hospitalization, and quality of life. So this is the summary or the basic steps when you are doing or conducting research. You have to start with the population, defining the inclusion and exclusion criteria, end up with a selected sample, then randomize them into the interventional arm and placebo arm, and set an outcome to be measured for the both of the group, and then do your analysis or a statistical analysis. So that will be that for the exercises. Now we are going to discuss the assignment.
Okay. Thanks a lot, Doctor. Very informative.
Do you have any question for me or Dr. Abdurrahman, Farhat, or any other?
Thank you, Doctor.
Thank you so much.
Okay. Hello again, everyone. So sorry we took a lot of your time. We're going to quickly explain the assignment. And thank you, Dr. Faisal, for the amazing presentation. Your assignment is going to be a study design and a presentation. It's going to be 10 slides, 10 minutes presentation, and 10 minutes discussion. Okay. You don't need to write a report, a paper report. It's only a presentation. Okay. So we will give you the scenarios. Use these given scenarios to make your study design and presentation. Tamam? You will form the groups yourselves and send the Excel spreadsheet with the full list of group and names. So separate Excel sheet for boys and separate Excel sheet for girls. Form groups composed of how many students? I would say 4 to 5 students, but let's ask Dr. Julian of how many members should be in one group. Okay, for the time being, I will confirm a few things with Dr. Julian. I'll come back to you guys, but for the time being, make a groups of 4 to 5 members in each group, and use the given scenario. Yeah, and once you form the group, send us the groups by 21st of September. So you have 6 days to form the group before you go on the National Day holiday. Okay. And you will also sign your contribution to the paper. So we have a paper that you will sign, but this will be at the presentation day. Okay. And the second session, which is on the 29th of September, you will deliver the presentations and you will be graded based on a rubric. I will also be sharing the rubric, or Dr. Julian will be sharing the rubric later, okay? And the marks will go toward your block grades, okay? So these are the components of your presentation. You will, basically, it's whatever we discussed today. You will type the research question you're addressing, and you will also break down the research question into the components of PICO. You will write the setting. You will write whether it's one center or multiple centers. Okay. You will the way the patients will be recruited in your study, the inclusion and exclusion criteria, and explain them and why you chose them. You will describe the treatment in the both group, the intervention group and the control group. You will explain the randomization process. You will talk about blinding. Okay. You will discuss the possibility of single, double, and triple blinding. Okay. You will define the primary and secondary endpoints, means the outcome. So what your outcomes of the study? What are you following up? What are you assessing? Okay, and what are you expecting? Okay, and also you will see the number of patients that is expected to be included in the study. So you will tell us, okay? And the instruments that will be used to assess the outcomes. Okay. And we need also a flow chart, like the one just Dr. Faisal just showed you. Okay, flow chart or diagram of your study. Okay. This is 2 advice for you guys. Once you've taken the scenario, there are 7 or 8 scenarios. Once you've taken a scenario, read the scenario, look into the internet or PubMed to find similar studies to the scenarios, okay, and learn from them. It will be an RCTs. Try to learn from them and see whatever they've done and why they've done it this way, okay? But the second advice is that most of the time, when you are making your presentation, you will be making things up from your mind, okay? And try to explain why you chose this to do it this way, okay? So it's your creativity that is important here, okay? That's it. Do you have any question regarding the assignment? Is the
Yes.
assignment clear? Okay, go
I
ahead.
have a question.
Yes, please.
Are the groups limited to our tutorial groups, or
Rakan, how many male students there are in
9?
your batch? No, in the batch, the whole thing.
In the batch, more than 40.
40. Okay,
More
so
than
if
40.
we have, let me just quickly check how many scenarios do we have. I think it's 7. Scenario 3. Okay, we have 4 scenarios, and you are guys 40.
Yeah, give or take.
More than 40. More than 40.
Okay.
At least. Yeah.
So in such a case, there are 4 scenarios. You should be divided yourself into 4 groups because there are only 4 scenarios. However, I'm gonna confirm, and we're gonna post it in the e-learning. And once we post how many groups you should form, you will form it yourselves based on BBL groups or whatever you like, and then send them to us. Okay.
Okay. Thank you.
If Dr. Julian can hear me now, then probably she can decide how many groups you should have. If not, then I'm gonna speak to her and come back to you guys. Okay. Any other questions?
Thank you. Jazakumullah khair.
So if the assignment is going to be physical attendance, boys and girls will be separate. If it's gonna be online, then your guys gonna be together. However, we will be involved in the assessment of the presentation. So please make your own new presentation. Do not take the previous year presentations. Okay, understand the presentation. This is an easy marks for you guys. Do not lose it because you're not prepared well, or you've used something that's not yours from last year or whatever. Okay, we would like it's an easy job. There's nothing difficult in that. It should be an hour and 1 hour work or something like that. Okay. This way, inshallah, you will love epidemiology and statistics, and then you will work better. Okay. So is there any other question, or we can end up this session?
Dr. Farhat, I'd just like to add something, if you may. Yeah. So since the number of scenarios are 4 compared to the number of the students in each group, the male students, let's say, for example, so probably each scenario will be taken by 10 students, and I need, and I think all the fellows need, all the 10 students to be participating in this presentation. We don't need only like 3 or 4 students participating and the rest of the students stay without doing anything. At least they have to contribute in the presentation, because we may ask some of the we may ask all the students in the group, and they have to be prepared for that.
Okay, thank you, Abdul Ali. So before you go, guys, because we're gonna be together for a long time, inshallah, this year, and we will have multiple sessions. What I would like to do is that after each session I deliver, I would like to have a feedback. So I have put the link for feedback in your chat. Please send that link in your group. Ask students who attended today to provide feedback. It's totally anonymous if you don't want to write your name or whatever. This way we will improve ourselves. Please try to provide specific feedback for the session. Okay, so what did you like, what you didn't like, and how to improve. Okay, thank you very much. If there is anything that Dr. Nazmus or Dr. Julian would like to add, or we will be concluding our session. Okay, thank you very much. Thanks to you all. Thanks for your attendance, and see you inshallah soon. Have a good day, and bye-bye.
دكتور ولسي.
يا أهلا عز الدين. عز الدين، ارسل لي اللينك في الجروباتكم، تمام؟ اللي حضروا حابين يعطوا فيدباك، بالذات مثلا اللي طلعوا من نص الشات، ايش اللي خلاهم يطلعوا؟ هل هم مثلا شافوا انه boring ولا something else? If there's anything that we can do, we'll do. Okay.
تمام.
توفيق يا عز الدين.
سعدكم الله.
بقية الشباب. And Rakan, thank you, Rakan. You spread the news when I asked for someone to tell this your colleague.
You're welcome, Doctor. Thank you.
Yeah, thank you very much, Rakan. I'm not sure if you informed both the female and females or males or only males.
I did both.
Oh, I did both. Okay. Thank you.